Okay, Jo.
Okay, welcome everybody to our fourth in our series of webinars on palliative and end-of-life care issues, which is aimed at sort of district nurses or those working in the community. And so welcome to everybody today. Thank you for joining us again. And it's just a reminder that all of these sessions are recorded to people who have registered and will be available on the Cardiff University YouTube channels. So today we're going to talk a little bit about advanced care planning for sort of 15 or 20 minutes at the start of this. And then we're going to do something that's a little bit different rather than you just sort of listening to one of us present. And I've got a couple of cases that we're going to have a little look at and several members of a panel here that we're going to sort of talk through. And I'd be really, really grateful if you could sort of get involved in that discussion. There's not that many people on the call, so either by sort of speaking to us, ideally with your camera on, or if you're more comfortable or it's easier, you can put comments in the chat. Thank you. So as you know, this is a series of webinars run by Cardiff University and funded by Cardiff and Vale Health Board for healthcare professionals and those of us who are working in palliative care. So without further ado, I'm going to hand it over to my colleague, Karen Smith, who's a clinical nurse specialist in palliative care, working with the Marie Curie Community Specialist Palliative Care team in the Vale, but in a sort of previous life was Macmillan Advanced Care Planning Facilitator for Cardiff and Vale. So over to you, Karen.
Thanks, Jo. Thanks very much. So this is just about 13 slides on advanced and future care planning. So we tend to talk about advanced and future care planning here in Wales. Advanced care planning has been around for a long time, and many of you will already been doing it in some form or another. So let's try and get my slides to go forward for you. Yeah. So what sort of things do we plan for? You know, we like to plan, those of us that are sort of working and juggling families and our lives outside of work, plan all the time, don't we? So plan for lots of different things. Retirement might be something that's very prominent on your mind if you're at a certain age. Planning for children, sometimes we don't get that choice, it just happens, sometimes it doesn't. Planning for a nice posh car to make up for the one that we've battered around the community for years, and try to get the smallest one possible so that it can park into those spaces down in Roath. Planning for holidays, yeah, that's why we're all working, so we can have time away and enjoy ourselves. Planning to move house, and some of us and some of our patients will plan for their funerals. They'll have told you they've bought their plot, they'll have told you that they've planned their music, that they know what they want for their funeral. They don't want a set service, these sorts of things. But they often don't tell us what's important and what matters to them when they are actually dying. So what is advanced care planning? So as I said earlier, lots of you probably already do this in one way or another, talking to your patients. And there's a European consensus definition that says that it's a chance to offer people the opportunity while they're still well to define their goals and their preferences for their future treatment, care and support, and to discuss these with their family and healthcare providers. So it's all very well them talking about it and deciding things, but they need to tell us as their healthcare providers. And sometimes those conversations come up while you're doing a leg dressing or they've just come back out of hospital. It's shaped towards the individual. There's no one size fits all. And that, I think, is probably what makes it seem like quite a strange beast to deal with, because if you ask any of us what it's about, everyone will probably come up with a different reason for doing it. But at the end of the day, it's about not doing unwanted and unnecessary things to our patients that we know that they actually wouldn't have wanted. So who needs advanced and future care planning? Anyone. Any one of us. It doesn't really matter, any age, you can start thinking about the things that matter most to you. Obviously, someone with a life-limiting diagnosis, it becomes more pertinent to them because we need to start knowing what's going to happen to them, and we need to plan and work out what we know is going to be manageable and doable, and make sure that their expectations of what we can do for them are realistic as well. I was going to ask this, but of course I can't see what the answers are because I've got my main screen up. But if you think about one group of patients for whom having this conversation early in diagnosis is important, if you think about those patients, and those are probably the patients that we see with dementia, and they may not be diagnosed until quite late. So having conversations with them, and certainly from district nurses, you'll probably have these conversations. They've come out of hospital, they've had a long stay, and they'll say they don't want to go back in there again. They want to stay home. They want to be with their cats, their soaps. They don't want to be stuck in the heath and not be able to have visitors and things if we go through another round of COVID again. So it is important that these conversations are had, especially with this group. NICE guidelines have said that we need to offer early and ongoing opportunities for people living with dementia to start talking about their future plans. And that's vital, because we know at some point they're going to lose that capability. And obviously for people with fluctuating capacity as well, it's very important that we encourage them to start talking about the things that matter. So when would we start looking? That's sometimes people say, oh, well, when do we start planning? Whenever it seems appropriate. You know, the patient asks you themselves, and says, oh, I've had this diagnosis, I'm really worried, I want to start planning for things. And they might ask you what you think is reasonable, or they might ask you about things like lasting power of attorney, making a will, the sorts of things that we know as nursing professionals and health professionals, the things that matter to us, and sometimes that can colour how we react to being asked questions about these things. But obviously we need to remember that it's what the patient wants. And certainly we've seen it, we've done sort of advanced care plans with patients with COPD who will say, I don't want to go back onto B7, they're really lovely there, but it took me so long to get back home, I just want to stay home. But then when their respiratory rate is climbing and they're starting to feel really scared because they're breathless, they're likely to turn around and ring 999, because being back on the ward is somewhere where they feel safe and they have that sort of cocoon of staff around them. So after multiple admissions, we know in the last year of somebody's life, it's likely that they will have more admissions and more infections. At the diagnosis of a life-limiting condition, obviously if they're sort of frail and have multiple comorbidities, and we're seeing a lot of very elderly, very frail people saying they want to stay home. And that surprise question, would you be surprised if this patient were to die in the next year? I think if you're seeing them getting more infections or more hospital admissions, then that you'll sometimes get those discharge letters come back, and you'll see, please talk to this patient about advanced care planning. This conversation can happen everywhere. It doesn't have to happen in the community. Then I think the more of us that mention it, hopefully patients will start to think of it as a good idea and not something that's being forced on them. And a life-changing event, that could be that their partner's died, that they've moved into a nursing home or care home. These sort of things can be triggers. They've had a long admission into hospital and are just getting home. These sort of times are when we should start thinking about, well, what happens next time this happens to you? Why is it important? So if we look from the patient and the family and the carers around that patient, it's patient-centered. It's what the patient wants, and sometimes that can be difficult if their family are worried or concerned about them. And remember, we always say patient has capacity unless we know otherwise, and trying to sort of be realistic with them. If they can manage at home, then we try and do everything we can to manage that, don't we? It's about choice and control at a time when they might feel they have none, and supporting them to achieve those goals. And it promotes the discussion. It might not be a one-off discussion. It normally isn't. This is a conversation that you start and you might come back to several times with them. But if they want to have that conversation, then you start the ball rolling. If you don't feel experienced about doing it, maybe find somebody who does want to talk about it. Watch how they do it and pick up hints. That's how we've all learned, is by watching others do things. We know that if we manage expectation for patients and their families, we can help to reduce conflict, and hopefully for the family that's left behind, it's a better experience for them because they know they've fulfilled the wishes of that person. There will be people who don't want to talk about it, and obviously that is absolutely okay. document that you've tried to have the conversation with them, make sure that people know that you've tried to have that conversation, and then if something does happen, the chances are, if people haven't made care plans, they are going to end up in hospital. But otherwise, if you can try and get them to at least say where they really would like to be. From us as healthcare professionals, it's clarity, isn't it? If we know what the patient wants, it makes life a bit easier. Those Friday afternoons standing in the GP surgery with a sort of a prescription chart for drivers, you're doing all the right things. It's a collaboration. We don't just work in a bubble and a little vacuum. We're working as a group, that's sort of with the hospital teams, the community teams. We all work as a big team, even if we're all not in the same office. We do need to collaborate as much as possible. It's patient-centered care, which obviously is important, and it's prudent healthcare. We shouldn't be doing things to patients that they wouldn't want us to do. And that hopefully will start to impact on things like coming in for clinics. Do they need to come in for clinics in that last year of their life? Do they really want to be coming in to a clinic? I wouldn't want to be sitting on an ambulance and sitting on a sort of an hour journey into the heath for a visit where I'm going to be seen for 15 minutes. So these things all impact on patient care and resources. It's about quality, so we know that we're providing a quality service for our patients, and about setting realistic goals for them. Hoping this is going to work. This is a little video by Dying Matters, and it just shows the importance of that thinking ahead and finding out what matters.
Dad? Dad? Dad?
Brenda, are you okay?
Dad! Dad, you frightened me, Dad! Dad!
Grandad needs to go to hospital.
But why?
Oh, sweetheart, look at him.
Don't.
Don't what?
I'm not having a go. I'm just saying, why can't he stay here where they can send experts to look after him? At least then he's surrounded by people that love him. You know him. He's your dad.
I do know him. I know exactly what he wants, and he doesn't want this.
Hey, what would you do?
Never mind what I do. This isn't about me. I know what he wants, and you don't. He's going to hospital, and that is that.
I'm so sorry this has happened. I know you wanted what was best for me, but I didn't want that.
Your brother's talked a lot about you. He's got very fond memories of you both growing up. Now, David, your brother is very poorly. And he's reached the stage where I'm afraid we can do no more to actively treat his cancer. What we can do is keep him comfortable and pain-free. I know this might be difficult, but did your brother ever talk to you about resuscitation?
Okay, we've got Gareth, hypertensive, found collapsed at home, pulse rate 120. We just realised he stopped breathing.
Well, at this stage, cardiopulmonary resuscitation would not ultimately be successful.
Gareth? Gareth?
I don't think resuscitation would give any benefit to your brother at all. What are your feelings about that?
He's too young to die. I want you to do everything you can. Okay, so we've got 3S. I'll charge you. Carry on with chest compressions. Everybody else stand clear. Please don't let him die. Stand clear. Shocking.
I know why you did it. That really hurt. I didn't want that.
Get all this stuff loaded up.
No, it's fine. It's yours. All right.
Okay.
Yeah, mind them ducks.
No.
I'll tell you what, they're nice then. No, a lot of room.
Nice to get down at the pub. What time's the next job?
An hour. All right.
We've got an hour.
We're good. Mind your ass. All right, don't know about too much, will you? You all right, love?
Come on then. You carry this one.
I wanted her to be looked after. I didn't want that.
I might be gay, but I'm not a stereotype. I didn't want that.
You get nothing from there. I think so they come in up. Six. Oh. Aye.
He was all I had. I wanted him to be looked after. I didn't want that.
I do know him. I know exactly what he wants.
Staying clear, shocking.
If there are things you don't want, as well as things you do, you need to make plans. Dying Matters can help.
That gives you some of the scenarios that that we can have, and I think the one with the family arguing about what to do with Dad, I think a lot of us have seen that one before. We've been in the room when that conversation's been happening, and it's not nice, is it, for any of us? Not nice for the patient either if it's happening around them. So the Welsh perspective, Advanced and Future Care Planning, there was a conference a couple of years ago, and we spent a whole day chatting about what we all wanted and what we wanted to see in Wales happening. And some people would say, well, what's the difference? So advanced care planning is for patients who've got decisional capacity. Like I said earlier, we always presume people have capacity unless we've got a reason to doubt that. If we've got somebody who's got fluctuating capacity, and obviously if they've made decisions while they had capacity, those decisions about what they would want are sort of are lawful, and we should try our best to try and follow them. There's obviously there is a difference between something being legally binding and something being lawful, and you should always have to sort of say if you haven't managed to follow a plan, you should be able to say why you haven't done it. Future care planning, that's our best interest decision making, and I think, I mean, I must admit there are still times I call it best interest decision making, and that's for these individuals who lack decisional capacity. They cannot make informed decisions, and obviously in those circumstances we speak to their friends, we speak to their family and try and find out what mattered to them. It's about frank and honest conversations, and it must be delivered compassionately. We must be able to have time to have these conversations. Sometimes you feel like they happen over a garden gate as you're heading towards the car because the family haven't wanted to start talking about it in front of mum and dad. So it's obviously pointing them in the right direction to be open and frank with their parents and find out what their patients and their family want, and then maybe bring us in to write that down and document it for it and make sure that it, the ambulance service and the GPs all know what this person wants to happen. I put a link there that you can click through to, and that has more information for you as well. And there's a QR code. I'm not sure if the Cardiff and Vale intranet is still working, but there's an advanced and future care planning site on there, or there was, with lots of links and leaflets if you wanted them. Documents, we've got our advanced care plan, our Form A, and as the sort of CNSs, and I know some of the district nurses have used those, and it's to guide the clinical decisions. It's not, like I said, not legally binding, but it's lawful, and it's there to guide our decision making. The future care planning, or the record of best interest for those that lack capacity, again, not legally binding, but a record of previous decisions that have been made, and it can help when someone has lost capacity. The treatment escalation guide, the treatment escalation plan, that's about actively avoiding hospital admission, and that can be really useful if you've got somebody who's having frequent admissions, and if that's somebody with dementia, obviously coming into A&E. Having worked in A&E for a long time, A&E is not the environment for someone with dementia who's scared and wondering what's happening. It's loud, it's lots of strange noises and people they don't know. And again, that's not legally binding, but again, it's lawful, so we should try to follow that. And our advanced decision to refuse treatment. So this is something that someone with decisional capacity can decide to put in place. So they may have been diagnosed with something like MND, and they may have decided they don't want to have a PEG fitted. They may say, oh, I don't want to have any invasive ventilation, these sort of decisions, and they can actually state the treatments that they wouldn't wish to have. And that is legally binding. And obviously, if we do something to a patient, knowing that there's an ADRT in place, there would be serious consequences for that. So looking back, our sort of principles of advanced care planning, it's about managing expectations, and that's the people coming out of hospital and thinking that the district nurses will be in 4 times a day, and we know that very rarely is that the case. So it's making sure they understand what is available. It's about a holistic, everything. When we talk about palliative, we take a very holistic view. The dog in the video, how many of us have talked to families about what's happening to cats and dogs, ducks, these things that they might need to rehouse. It's voluntary, so patients don't have to do it, but it's a good way of ensuring that their voice gets heard at the end. Demonstrate how those decisions have been reached and who's been involved in making them. That can make things easier in the latter stages where there might be conversations about, well, who decided this? People can't demand treatment and care or ask for their life to be ended. And that's the other thing. We talk about DNA CPR and we always involve families, but it's a clinical decision at the end of the day as well. And I think it's worth sort of saying that when people want to stay out of hospital, a really good way to stay out of hospital is not to have CPR initiated in the community, because you are then being taken to hospital. Signpost people to other health and social care professionals when necessary. It can be initiated by anyone. It doesn't have to be health and social care. It can be someone in their church who's spoken to them because they know that this is someone who needs to make plans. Like we said earlier, the document is a guide for treatment and care. It's not legally binding, but an advanced decision to refuse treatment is the one that's legally binding. So people will normally tell you, I've got a living will, I've got an advanced decision, and they'll let you know because they're very certain that they don't want to end up in critical care. It's about appropriate care and appropriate treatment. It's the right place, the right time for the right person. And a lot of the things that we do in A&E when people come in, that's not what we should be doing to someone at end of life. But it doesn't mean that we don't do anything. And we need to reassure people of that as well. Who can be involved? I said earlier, anyone. It probably will fall on us as healthcare professionals, because we're the ones that know the implications of ending up without a plan and without people knowing what we want. And we do encourage people that if they're writing one, to talk to somebody who is a healthcare professional, just so they can make sure that it's a plan that stands a chance of actually reaching the goals that that person wants. Don't let someone miss out on having their voice heard. It is a scary conversation. If the first time you do it, you feel like you're invading their privacy and asking things that are intrusive, and you don't want to upset them. But actually, even if they say no, at least you've tried to have that conversation. And it might be that they want to have the conversation and you're the first person that's mentioned it to them. Have they got communication difficulties? Do they need speech and language therapy to provide a way of communicating with you if they are so far ahead in their disease that they can't speak to you? Then can we make sure that they have the ability to do that? They've got fluctuating capacity. You talk to them while they're well, not while they're unwell. Don't wait for the patient. Ask them, would they want to talk about their future plans? Empower patients early in their diagnosis to start talking about it. Don't make them feel that it's wrong to ask, and make sure everyone knows the plan exists and where to find it. And that's why I put the message in the bottle. Welsh Ambulance Service, if they see that little green cross on the door, they know to head to the fridge and go and find the paperwork. If there's a lot of paperwork, I always say, just put a little note in there saying it's in the bureau, in the dining room, in the pink folder, so they know how to find it quickly. How people die remains in the memory of those that live on, and that's not just for the families, that's for us as nurses, as healthcare professionals. So if we can make sure it's a good ending, a good death, then I think we all feel a lot happier about it.
Thank you so much, Karen. If anybody has got any particular comments or questions, put your hand up or put them in the chat. And meantime, because it's about 1:30, I think we'll move on to the cases, if that's okay, and we'll pick up questions as we go. Is there any further comments you wanted to add, Karen? No.
No, Jo, I'm fine, unless anyone wants to put anything in the chat. I can answer that for them.
Yeah, we'll pick up the questions from the chat. So I'm just going to put a case up, if that's okay, for us all to have a think about, and then I'm going to introduce the people that are on our panel, where we're going to have a bit of a chat about collaborative working with palliative care type patients in the community and how we can try to plan ahead, if that's okay. So I'm just going to share my screen. Okay, Karen, you're the only person I can see. So can you see my slides?
Yes, I can.
Great. Okay, thank you. So everyone should be able to see Brenda, who's 75 years old and who's at home. She's got COPD. She's had lots of hospital admissions this year, and she's had lots of hospital treatment, sort of, IVs, antibiotics, steroids, a couple of attempts at NIV, which she hasn't tolerated, and she's been pretty clear that she doesn't want to try that again. She's becoming increasingly frail with weight loss and appears to be deteriorating by the week. She can just about get from one room to another in her ground floor flat, but that's about as far as it goes in terms of her breathlessness and exercise tolerance. And she's got, for those of you who are interested in lung function, she's had an FEV1 of less than 30% when it was tested about a year ago. Okay, so Brenda lives at home with her elderly husband, who's also got significant health problems. She's got some children who are local carers. She tends to call 999 when she's breathless and panicky, because she's not quite sure how else to help herself or how to summon help, but hates being in hospital and self-discharged a couple of times recently. She's on some medicines there, so she's on long-term oxygen, as you can see in the picture. The inhaler there is one of the sort of new combination inhalers that will have a bit of a Ventolin type medicine in it, a bit of an anticholinergic and probably some steroid. She's on some long-term azithromycin there, which is for its antibiotic and anti-inflammatory uses, and she's got a COPD rescue pack. So have a little think about Brenda. I'll just go back one to the previous slide, if that's okay. Sorry, previous. And while I do that, I just want to introduce our panel, if that's okay, or perhaps I could hand over to you, Fiona, because I now can't see the people on the screen. Would you be happy to introduce the panel and just kick off our discussions?
I can certainly do that, and welcome everybody, and thank you very much, Karen, for starting. So on the panel, as just sort of going down the list. So Catriona, I can see you on my screen. Do you want to wave? So Catriona and is there with James Davis from City Hospice. So CNS from the community in City Hospice, and Joe, I guess you and Karen are thinking of the specialist palliative care team for the Vale. I can see Emily there, who is a GP up in Rumney, and I can see Jackie, who is here as district nurse. Thanks for joining us, Jackie. And I could see Stefan before. There you are, Stefan. Thank you very much. Yes, great. Who is one of the nurse assessors. And I can see Ed O'Brien. Lovely to see you, Ed, who's here from Welsh Ambulance Service. And have I missed anybody from the panel? Please shout at me if I have. I think I've got everybody. And of course, we've got all of you else on the call. So, Joe, kind of how do you want to bring people in for their views? How do you want to play this? It's such a common. I can think of a Brenda. I can think of a Brenda from a visit to a patient about probably 2 or 3 months ago, and it was that sense of, but I'm get anxious, and so what do? I call 999. So Joe, how do you want to play? How do you want to play it?
So I was trying to think of a logical reason with a logical person to kick off with, but it very much depends. Any one of the people on the panel might be the first person to sort of encounter Brenda in this particular crisis, mightn't they? Yes. So I wonder if we should we start by going through the panelists, getting them to give a quick sort of summary of their thoughts, and then we can go to our audience. And I was wondering if we might start with Emily, perhaps from a GP perspective, or Jackie. But yeah.
So fantastic. I'm actually going to suggest Jackie. Can you go first? And please, folks, add comments in the chat as you think. So Jackie, what are your thoughts on Brenda?
Okay, so straight away I'm thinking if I was called here, you'd have to have those sort of honest conversations and discuss, she's ringing 999, because she's panicking, but what is her expectation if this rescue pack and everything isn't enough? So you're looking at maybe getting anticipatory medication, things like that. But after a conversation, I'm also thinking, they probably need a bit more care. So you'd have to get some other services involved because they're only having 2 care calls a day. Her husband's also frail. So can we get some more support in to help them? Equipment, is there any other equipment that might make it easier, or adaptation? So you might want to get physio OT to look at the home environment, see if we could make it a little bit easier with the adaptations for her to manage in her own home. And I think, is there any other sort of support groups? I know that there are fewer, but then it's not as many as there used to be, but breathing exercises, things like that. I don't know if they're out there, but is there other services that might be able to help this person? But obviously as well, you'd get the palliative team in and talk about what her expectations are for the future, how we can manage it, how we can keep her comfortable in a home, less sort of anxious maybe, and support in that way with equipment, adaptations and any other support we could get in, really.
Fabulous. Thank you very much, Jackie. Emily, I'm going to come to you next, and then Ed, I'm going to ask you to come in after Emily. But Emily, from the GP perspective, what else would you add to that, if anything?
Well, she's got quite severe COPD, and she's on maximal inhaled therapy, and she's also on long-term oxygen. She tends to panic when she's a little bit breathless. So as Jackie said, some breathing techniques, such as handheld fan and, positional breathing and things. That sort of advice may be helpful. I know that Marie Curie's got a really good article on their website about, breathing techniques and positions and things. So maybe directing her to that may be useful. She's also someone I might consider a little bit of Oromorph for. If she's on maximal therapy and she's getting breathless, maybe a trial of a low dose of Oromorph just to see if that helps. That might calm her down and, kind of stop her from reaching 999. And maybe also sort of an exploration about anxiety in general. Is it the breathlessness that makes her anxious, or is she anxious about other things and then feels the symptoms of panic, which include breathlessness? So maybe if she's got an underlying anxiety, she may be, a treatment for anxiety with another sort of medication might be beneficial. And she said that, she's self-discharged, she doesn't want to be in hospital. So maybe broaching the subject of an ACP and, having a plan of what we do when, instead of going to hospital, maybe there are other people she can call. She could speak to the GP during daytime hours, she could speak to out of hours, and, maybe just sort of giving her alternatives to call if she feels that she needs help.
Fab. Thank you so much. Ed, with your Welsh Ambulance hat on, what would you add to the discussion?
It's hard to add anything now, isn't it? Because most things have been mentioned. So from an ambulance point of view, this is a really regular patient that we go and see. COPD, breathlessness is such a common treble 9 call for us. I think it's probably important that I point out that when we walk into these patients, we have zero background knowledge on them. So we are literally just walking into a patient where we'll be told difficulty in breathing. And until we walk through that door, we don't know if that's a chest infection, a COPD, a lung cancer, an asthma. It could be anything. So the first thing that we'll do is information gathering. What does the patient look like? What can we see? Clues in the room, i.e. the home oxygen, for example. The fact, how does the patient look in terms of cachexia, etc. Our primary goal would be, let's try and make this breathlessness a little bit better first. So no doubt we would likely consider nebulizer. So we go for salbutamol, ipratropium bromide in the first instance. Whilst continuing to information gather, we pick up on COPD, we pick up on multiple hospital admissions. The fact there's home oxygen there is a little bit of a clue for us as well as to where they are in terms of their COPD. We've been considering then things like, I don't want to sound facetious when I say that, but the amount of patients I've seen where they've got that bottle of Oromorph sitting next to them and it's full, and you say to them, have you tried your Oromorph? And they say, no, it doesn't work. And you think that's because it's still in the bottle. I think there's still a lot of patients who will try it once, don't get the wonderful experience they're expecting, and they never try it again. So often we'll have to prompt them to try and take it again. If they haven't got Oromorph, obviously we've got morphine, we could consider subcut, perhaps 2.5 of morphine if appropriate. But often I think what someone's already alluded to is the underlying cause of the breathlessness. I think for some strange reason, as a person in green walks in, we seem to just have this ability to just make people a little bit less anxious, as I'm sure is the same with when DNs walk in. They just see a uniform and they think, okay, things are a bit better now. So yeah, it might be a case of sitting with them, talking with them, finding out a little bit more. And then if we're on top of this breathlessness and we're aware of the rescue pack, etc., we would likely then link in with the patient's own GP or GP out of hours, having had a conversation to find out what the patient wants. And we know that this patient doesn't want to go to hospital. And then we would perhaps talk about some options for home treatment with the general practitioner or the out of hours GP, and sort of take it from there. Often the GPs will sort of come up with a great plan, and between them and the paramedic, and often they'll also say, I'll do a home visit either today or tomorrow, and that's usually enough for the patient to say, do you know what, that's good enough for me, and the call will be closed down from our point of view. That's not to say we won't meet them again in a week's time next time they have breathlessness, and that's not because anyone hasn't done their thing, it's just because their anxiety is built again.
Fab, Ed, thank you. That's a really, we're really picking up this collaborative approach and working together. Thank you. Before I come onto the specialist team, Stefan, just with your kind of slightly different approach to this situation, what are the things that you would be thinking about?
From a nurse assessor's perspective, we've identified that the patient's got COPD, but we're looking at the needs associated with her COPD. So looking through 12 domains, her nutrition, her weight, her continence needs, her skin integrity, and as what Jackie's mentioned, looking holistically, involving the OT and other professionals. But for me, of particular interest would be the fact that she has got a twice daily package of care, which is single-handed. So I would be looking at who's set that up. Has the social worker set that up? If there is a social worker involved, brilliant. They'll have a wealth of knowledge of this individual, which we may not know. So social worker is a huge pool of resource which we can go to. At times, people do they do set up their own arrangements and they do it privately, so they don't do it through social services. So maybe a cause of her anxiety would be the fact that she feels that 2 calls a day single-handed isn't sufficient. She lives with a husband who's got his own comorbidities and has 2 sons who are living locally. We don't know how much support they're able to provide with maybe personal care, continence care, something which could be a very sensitive subject to her, maybe a cause of embarrassment if her sons, she may not want her sons to assess, so maybe these things are triggering her anxiety as well. So maybe working with the social worker in this case, or the family if it's a privately obtained package of care, to increase the package as per her needs if she's got additional needs. There's also a few risks which highlighted to me if this was presented to me, if a fast track assessment came in. Whilst I don't think she's at that point where we need to consider a fast track assessment, it will be at some point down the line. It is going to be imminent, but at that point I'd be thinking of the risks, and the risks should be thought about now as well, in terms of the long-term oxygen therapy. There's a fire risk, so I would like to think that the community respiratory team are closely involved with the management with that, and there's a care plan associated with her oxygen therapy. So yeah, working collaboratively with the district nurses, the GP, looking at potentially an advanced care plan. What are her wishes? Does she want to be cared for at home? Does she want to go into a nursing home? Would that give her additional reassurance that she's got someone available to her 24 hours a day? So I'd be looking specifically at her care needs associated with her diagnosis and how we can support and care plan to meet those.
Stefan, thank you very much for adding that. And moving to the specialist team, so I think probably if I ask Catriona and James, just from the point of view of community, and then Joe, I'll come back to you and to Karen, but starting with Catriona and James.
Yeah, no, go on.
the things I was thinking about was thinking of this from a different point of view, not of people who've been in hospital. Working in hospital palliative care teams, often you get, I'm in certain hospitals, it's been kind of, well, people coming in with COPD, you've got to stop it happening. Well, actually, for some people, that might be the right thing. So I'm coming at this from a very different angle, because I think it's always about hospital avoidance. But actually, for this lady, that might be what she wants, and it's hard to plan when somebody's unwell. When unwell, what they want. I think what we need to do here is to try and plan with her what she wants when she's well. Because if we're trying to do it when she's having an exacerbation of COPD, it's going to be very difficult because she's going to be breathless and anxious. So I think it's thinking about planning when she's well. And I think one of the things is yes, she's self-discharged from hospital, but I don't think we can say that means she never wants to go to hospital again. It may just mean that when she's feeling a bit better, she wants to get home straight away. So it's actually being clear with that person. It's back to, I think, where we start with a lot of patients, or with all of our patients, is actually being clear about the advanced care planning and being honest about what potentially could happen. And if you went to hospital, you may not come out of hospital. Okay, that may be okay. But then I think depending on whether it's an absolute no to hospital or whether it's I'd prefer to avoid it, would probably judge what I do. But I think having a clear plan for that person in a time of panic, you need it written down. You need the family members to be aware of it, so that when, think about it, any times I panicked, if I try and remember my own name, it's difficult, let alone a plan. So it's trying to do that when someone's well. So people like the ambulance service, Ed in Was, actually, you've got that information to hand, so we can follow that. And then it's kind of, well, has this worked? Great. If not, what's the next step? So it's back to having that conversation, but having it at the right time and trying to avoid having it just during these times of crisis is what I was thinking.
And I think it's, as Karen said in the teaching, ACP discussions happen continuously. So sometimes it may be something that we develop over a number of weeks or even months. And people can change their minds. So maybe someone starts off by wanting to go into hospital, but actually as their disease progresses, they may find that actually that's not the best interest for them. And picking up on what a couple of other people have said. So, for example, Ed, obviously, there's the reassurance when someone comes in with a uniform and you've got the nebulizers and other things there. But sometimes we can put things in place like nebulizers and talk through how to use them. So they've got that as a step. So make sure they've got the Oromorph. And if you've got the specialist team going in and reviewing, monitoring how they're using it, actually find out if they're using it appropriately, gaining their confidence with it. Do we need to get nebulizers in? Do we need to get, our wonderful OT who does be inspired with breathing techniques, and kind of pull in everyone together to try and keep this person where they want to be.
Fab, thank you. Really, really important points. I'm conscious of time because we do have another case to discuss, but Jo, just very quickly, is there anything else that you wanted to bring in on this one, Jo or Karen?
I think most people have said what's needed too. I completely agree with James that planning when she's well and not in mid-exacerbation would be good. I think if this is someone who doesn't want to go to hospital, but still wants the exacerbation treated as best it can be in the community, then we do need to make sure that we do that. And I ran this case past one of the respiratory consultants who said, there's no particular reason for this woman to come to hospital. I don't think she's going to particularly benefit in any case. But to treat properly at home, you would do things like send a sputum off, make sure she's taking her rescue pack stuff, which will include steroids and antibiotics, and either get her a nebulizer if she's not got one already, or at least make sure she's taking an inhaler through a spacer and that sort of thing. And Ellipta doesn't have a spacer, so it might be, swapping, so optimizing her COPD treatment. And then agree with Emily in terms of symptom control, things like Oromorph would potentially be helpful for the breathlessness, and maybe anxiolytics like lorazepam. And then I did ask one of my AHP colleagues if she could join our panel, and she wasn't available today, but breathing exercises, relaxation and all that stuff I think would potentially be useful. And then I think when you're planning when she's well, it's about getting everyone's perspective and giving people the information that they need. And I know that Ed, when he has a chance to speak again from the WAST point of view, would say that lots of people have got advanced care plans, but they don't particularly contain the information that's needed when you're a paramedic at 2 a.m. and somebody's phoned because they're breathless. So just thinking about what information we need to write down.
Ed, do you want to come in on that one just very quickly?
I think Jo summed it up quite well. I think what I would fully agree with is the process of advanced care planning is massively important, and nobody would throw stones at that. But I think too many people hang their hat on what they call as the advanced care plan. From an ambulance point of view, it's not a plan. It's a bit of paper that says not a lot of things that are helping us at 3 o'clock in the morning when we've just rocked up and we don't know the patient. ACPA, for example, doesn't even have past medical history on it. I mean, what use is that to me as a paramedic if I don't even know what's wrong with them? I'll stop there before I cross the line.
Thank you, but really, really, really important points. Thank you. Karen, I'm going to take a great liberty and say, can you hold fire on this one? What I'd love to do, folks, is that we've got 10 more minutes of the official call. Can we quickly look at the second case, because it's slightly different with a slightly different slant here. Joe, do you want to introduce the case? And I'm going to go around and again, do please add comments in the chat.
So we've just got Zahi's 89 and he has dementia, heart failure, previous stroke, and is quite frail and would have a clinical frailty score, for those of you who like scores, of 7 probably. Bedbound for the last 2 months, sleeping a lot, really poor swallow, feeding at risk patient really, who uses some thickener, but does cough and splutter when he's trying to eat and drink, and has got really attentive family with his daughter and her family who are all around, who spend a long time trying to feed him and make sure he's hydrated and get nutrition into him. But he is deteriorating now, appears to be deteriorating very quickly, and is different each day. And today is much more chesty, restless, less responsive, and feels warm to touch, let's say. And it's about how we all in our various roles might approach that. Again, it might be any one of us that is the first to arrive at the sort of, crisis, or today's scenario, mightn't it?
Thank you, Joe. Jackie, can I put you on the spot? Can you get in through that front door first for the purposes of the discussion at the moment?
Yeah, of course. And I suppose in this case, you think, well, they've been in bed for 2 months. I don't know, but I'm presuming that this is where the importance of working collaboratively with other disciplines might come in, as much as we might have already met this patient and had sort of a plan in place. I don't know. But if we haven't, and you were just called in for that, obviously, you'd think, well, they're not swallowing, they're chesty, restless, but are they swallowing anything? Is there maybe, in this case, a reversible cause? Might it be that they might be able to take antibiotics? I don't know, but it's from that, it looks more that they're deteriorating quite rapidly and might not be able to be treated for anything reversible, in which case, obviously, you'd have to think, okay, is there an advanced care plan? Has that been discussed? Is there a resuscitation in the home? What are the daughter and her family, what sort of has their role been? Has there been sort of discussions with palliative team, with district nurses, with GP as to where we go from here? And obviously it might be, is there anticipatory medication in the home? If they are not able to swallow or have something reversed, it might be that we need to quite urgently get those things in place. So and obviously checking the same old thing, is the equipment that's in there enough? Is this person, do they need to be kept comfortable, sort of end of life care? And in which case, obviously we'd work with the palliative team and in order to manage and the GP in order to manage and their end of life sort of medication, injectable, whatever, and keep this person comfortable. But I think it's a lot depends on if we know this person, where we go from here, and if they have any advanced sort of wishes. Yeah.
Thank you, Jackie. That's fantastic. Stefan, can I bring you in at this point, and then I'm going to go to Emily. But can you, what are your thoughts?
Yeah, of course. So Jackie may have been, and she may have thought as well, that it may be worth completing a fast track assessment looking at potentially fast track 1 eligibility. So she lives at home with her daughter and her family, but do they need support in caring for their mother, their loved one? Her mobility has obviously changed in the past 2 months, so there's going to be a lot of manual handling considerations, and she's just staying in bed now, which would be the most, as it says, it's bed bound. So that may be worth considering hospice at home services if prognosis supports that she's a fast track 1, or looking at getting a domiciliary package of care, because the family will burn out quickly. From what I can see, her needs would be quite high. It would also be worth considering what equipment is in place. So has she got the appropriate pressure relieving equipment? We want to prevent the development of pressure damage. And as Jackie's already mentioned, looking towards, again, anticipatory medications in the property. in advance, so that they can be utilised when needed, working with the GP and other health professionals involved in her care to, again, care plan and support her needs.
Fab, thank you. And I think that point about burnout is so terribly important for carers. Thank you. Emily, you're the GP. You're starting to get calls, or you might have got a call from the family before Jackie and colleagues have gone. What are your thoughts?
Well, just before this webinar, I did a home visit, and I think I just did a case very similar to this. So I hope people agree with me when I say what I'm going to say. But from from the history, it sounds like this person is end of life. They've had a gradual deterioration, being bedbound, sleeping a lot, poor swallow, and then things seem to have escalated a little, deteriorating now day by day. So I suppose we, as Jackie said, we need to consider, is this just, their disease progression, or is there potentially a reversible cause? Joe said that they were warm, could it be chest infection that's made them chesty, or is it, decompensated heart failure that's, made them more sort of chesty? So I suppose then we consider the appropriateness of, further intervention. Do they have an ACP? Would we gain anything by trying to get any antibiotics into them if their swallow is poor? Would admission to hospital be in their best interest with dementia? Are we likely to get a good outcome? And I suppose that's a decision to have with family and other members of the team as well. But my instinct from what it said is probably sort of end of life. So having that discussion about where the person, the best place for them to be cared for, can they be supported at home by family and care packages and things, as we've said, do they have the appropriate medicines there? If they're chesty and restless and less responsive, again, considering whether syringe drivers and things may be beneficial to manage their symptoms, and just making sure that, all of these things are communicated with the wider team, including district nurses and out of hours as well.
Thank you. Karen, can I bring you in from the specialist point of view? And then Ed, I'll come to you in a sec.
I think everything's been done already. It's that these are the patients, as you say, that it's looking after the family around them as well, isn't it? That it's just as much what we do as district nurses, as GPs, is looking after the family and ensuring that they feel that they've done everything. And what Emily has said and Jackie said as well, and Stefan, this sounds like a fast track. Reassuring them that mum is comfortable and relaxed and is where she wants to be is so important for them, because they need to know that they've done everything. They might want to go to hospital, but as we know, being stuck in an ambulance is it's not going to be easy for this lady with her dementia. So I'm hoping that the family are and they sound like a very caring family. So I'm hoping Emily's family earlier on were the same and felt that keeping them at home was the right thing to do. A&E they work fantastically hard, and it is, it's not for someone who is in the last days of their life. And that's me.
Thank you, Karen. Ed, just thinking, if you and your team's got a call, say, I don't know, a family member from far away comes back into the house and is anxious, how would you approach going into this slightly different scenario?
Yeah, and doesn't that always happen? You've got one relative who's looking after them, someone gives them a weekend off, and then they rock up and they call the ambulance. That is so common in ambulance world. I'm sure it's common in everyone's world. So everyone said everything already, and I'm just going to kind of echo everything Emily's already said. So yes, I'm leaning towards this is likely last days of life. However, absolutely, we're going to look for reversibles. Is that chesty because they need frusemide, or actually is it because it's secretions? Probably the latter, looking at the rest of the story. Yeah, it would be about us kind of getting as much information as we can, managing symptoms if necessary. So possibly some midazolam because they're saying they're restless, etc. Possibly, but we wouldn't autonomously make that call. We'd ring primary care or palliative care and say, hello, it's Ed, paramedic on scene. This is why we've been called. This is everything I'm seeing. This is my set plan. Do you agree? And it's kind of speaking with the GP then, and getting their thoughts, their take, and potentially, yeah, giving ambulance-based just-in-case meds if appropriate. And then, you know, our colleagues in primary care or palliative care then will help us with the, you know, who comes in afterwards, because obviously a PRN is only going to last a couple of hours, so syringe driver, etc., is going to have to follow. So I can't really add any more than that.
Thank you, Ed. Katrina and James, anything you want to add before I go to Joe? We're just about to wrap this up, folks, for those of you on the call.
I would just say the only other thing that we haven't really touched upon is the cultural and social importance areas that we need to consider as well. So if we're recognising that someone is actively dying and we're sensitively communicating that with the family and getting all the rest of these things in place, when we look at the 5 priorities for care of the dying person and we look at the Orwell's guidance, care decisions in the last days of life, an important part of that is actually making sure that we're supporting people's cultural, religious and spiritual views as well. So it may be that we need to sit down and say, is a certain religion important to them? Do they need a certain sacrament of the sick? Are they Muslim? Do we need to start planning ahead if they die on the weekend and make sure someone can get access to a death certificate quickly? So it's just remembering some of the other aspects as well that will be important to the bereaved when the person dies, and give them comfort that actually we've taken everything and we've tried to remember as much as we can. I think that's the only thing I can think to add, to be honest.
Great, thank you. Joe, coming back to you now.
I don't know that I've got anything in particular to add, to be honest, Fiona. I think everybody has said all of the things that need to be said, and I think it just does emphasise collaborative working in palliative care and everybody bringing their own perspective, really, and, you know, emphasises, if it needed to be emphasised, that these patients and families would get the best care from all of us if we're all working together and communicating with each other, really.
Thank you.
Yeah.
It is that communication is key, isn't it? You know, telepathy does not work. Brain waves do not work. You need to have a dialogue with another person. You need to hand things on. It's terribly important from the family's point of view. It's terribly important. I'm conscious that we're just past 2 o'clock. As with the previous 3 webinars, some of us can stay on the call until 2:30. If anybody on the call has got particular cases you want to you bring or mention, we will stop the recording at that point. But just before we stop the recording, I think this has, Joe, as you said, it has demonstrated so much the need for this collaborative approach. Palliative care, it's a team activity. Everybody does it, and just working together we can get the best experience for the family looking after the patient as well. So it's been a really interesting, slightly different format today, and I hope it's been helpful for people. I hope it's maybe given you some questions that you want to ask. But we'd just like to say thank you very much for joining us. Please evaluate the sessions. This will help us to plan for the future. It'll help us when we rerun the webinar series for our nursing home colleagues, which is going to happen in the new year. Unless there's anything else in the chat, then thank you so much for people who need to go. But if you've got questions or cases, then do stay on, because we're going to just chat for a little bit longer. But we realise some of you will need to go because you've got other things that you